Welcome back, students. This video is about the therapeutic uses of antimuscarinic drugs. So, you already saw the classification of the drugs and the pharmacological actions. So, if you see, remember the classification, we have natural alkaloids like atropine and hyoscine, and then we have synthetic and semi-synthetic derivatives and few miscellaneous drugs which have antimuscarinic activity. So here, therapeutic uses of anti-muscarinic drug we'll be discussing as the therapeutic uses of atropine as well as atropine substitutes. So what are atropine substitutes? They are semi-synthetic or synthetic compounds. They differ marginally from the natural alkaloids like atropine and hyoscine, and they produce more selective action on certain functions, and many of them have very less atropinic side effects. Okay, let's see. So coming to the uses of atropine and its substitutes. First uses, it is used as antispasmodic. Okay, so it can relieve spasm. You saw the action on GIT, it can relieve spasm. So atropine substitutes like dicyclomine, flavoxide, and clidinium are used as an antispasmodic. So they can be used in hypermotility disorders, in diarrhea or dysentery associated with hypermotility. They can also be used in traveler's diarrhea, irritable bowel syndrome. And they can also relieve colicky pain, both abdominal as well as visceral pain. Atropine is also used in biliary colic caused by morphine because it produces spasm of the sphincter of Oddi. So atropine can partly or partially relieve the spasm of sphincter of Oddi. Next, on the eye. So they can be used as a mydriatic and a cycloplegic. Okay. So they're usually used topically. So drugs which can be used as a mydriatic and cycloplegic on the eye, you have atropine, you have hometropine, you have cyclopentolate and tropicamide. So they are mainly used for diagnostic use, that is for testing refraction, errors of refraction. For testing errors of refraction, you need both mydriasis and cycloplegia, and fundoscopic examination of eye to visualize the retina. For fundoscopic examination, you need only mydriasis, you don't need cycloplegia. So you usually prefer phenylephrine for fundoscopic examination, but you can use anti-muscarinic agents as well. And in therapy, atropine can be used to provide rest to iris in iritis, iridocyclitis, etc. And they can be used as an alternative with a miotic. So, that's mydriatics and myotics, they can be used alternatively to break the adhesion formation between the iris and the lens. If you see the drugs, atropine is potent but has slow and long-lasting action. The pupil dilates in 30 to 40 minutes. Cycloplegia takes 1 to 3 hours, and the subject is usually visually handicapped for about a week because the action lasts for 7 to 10 days mostly. Hometropine is more potent than atropine, and the mydriatic lasts for 1 to 3 days, and the cycloplegia recovers in 1 to 2 days. Cyclopentolate, it is short-acting as well as more potent than atropine. It is preferred for cycloplegic refraction, iritis, and uveitis. Whereas tropicamide, it acts rapidly and has very short action. Even though they are unreliable, it can be used in refraction testing in adult and fundoscopy. As a pre-anesthetic medication, when usually irritant general anesthetics were used, prior administration of an anticholinergic was imperative to reduce the salivary and respiratory secretions. So they can prevent the development of aspiration and laryngospasm, and also can prevent bradycardia during surgery. Usually, glycopyrrolate is preferred as a pre-anesthetic medication. As a cardiac vagolytic, so atropine can abolish the heart block, AV block, due to excessive vagal activity, and occasionally they are helpful in countering the syncope and bradycardia due to hypersensitive carotid sinus. Organophosphorus compound poisoning. Atropine is a life-saving drug in organophosphorus compound poisoning. So atropine is usually given in the dosage of 2 to 4 milligram intravenous, repeated every 5 minutes. So every 5 minutes, you can increase the dose of atropine. You can double the dose of atropine till atropinization, or you achieve atropine targets. So what are the atropine targets? Heart rate more than 80 per minute, BP more than 80 millimeters mercury, and the chest should be clear. There should be no bronchoria or bronchospasm, and the pupil should not be pinpoint. So how is atropine effective in organophosphorus compound poisoning? So as you know, organophosphorus compounds are anticholinesterases. So you're giving atropine, which is an antimuscarinic drug. It will block the muscarinic receptors, and they are highly effective in countering the central as well as the peripheral muscarinic symptoms. But atropine does not reverse the ganglionic action and neuromuscular paralysis. So the first choice of drug in organophosphorus compound poisoning is atropine. You can also use oxons. Next, in bronchial asthma and COPD, chronic obstructive pulmonary disease. So you can use atropine substitutes like ipratropium bromide and tiotropium bromide. It is usually given by inhalational route. So these drugs, uh, atropine and antimuscarinic drugs as in general, they can reduce the bronchial secretions. They reduce the secretion from the glands, right? So they can reduce the bronchial secretions, and sometimes they can interfere with the mucociliary clearance. But when you give these drugs by inhalational route, they do not have much action on the bronchial secretion, and it does not interfere with the mucociliary clearance. So ipratropium bromide and tiotropium bromide can cause bronchodilation, can relieve the symptoms of bronchial asthma, and they are usually suitable for regular prophylactic use. In peptic ulcer, you can use pyranzapine and telanzapine. These are the atropine substitutes. They are selective M1 blocker. So they usually act by blocking the M1 receptors at the paracrine cells in the gastric mucosa. So they can reduce the gastric acid secretion and can afford symptomatic relief in peptic ulcer. So they are equally effective in treatment and in preventing the recurrence of duodenal ulcer. But you have more effective drugs like proton pump inhibitors and H2 blockers in peptic ulcer. In Parkinsonism, atropine substitutes like benzexol and benztropine can be used. So they are mainly used in drug-induced Parkinsonism. They are less effective than levodopa, and they usually act by reducing the overactive cholinergic activity in the striatum. So they can reduce the rigidity, tremors, hyperhidrosis, seborrhea, and celoria in Parkinsonism patients. In hypersalivation or celoria, so usually prefer synthetic derivatives like glycopyrrolate. So they can decrease the salivary secretion, especially during dental procedures and heavy metal poisonings. So they're usually useful in drooling, and they can also be used in Parkinsonism patients. As a vesicoselective, they can be used in urinary disorders. So drugs like oxybutynin, dicyclomine, propantheline, and tolterodine, they are used. They can be used in urinary urgency to reduce the frequency and relieve the bladder spasm. They can improve the bladder capacity following neurosurgeries. They can reduce the nocturnal enuresis in children and paraplegic patients. They're used in patients with diffuser instability. So urinary frequency and urgency, neurogenic bladder, urinary incontinence, and nocturnal enuresis can be relieved. In motion sickness, usually use hyoscine or scopolamine. They can be used orally or a transdermal patch. So they usually prevent motion sickness by blocking the muscarinic receptors in the labyrinth and vestibular apparatus. And it also has a CNS depressant property. Because of that, they can produce some amount of sedation. So they usually used as a prophylactic agent. They had to be taken half an hour before journey. Orally has to be taken half an hour before the journey, and if transdermal patches are being used, 2 or 3 hours before the journey to prevent travel sickness. Okay, and transdermal patches can be applied behind the pinna. It can release zero point 0.5 milligram over a period of 3 days. In case of mushroom poisoning, mushroom inocyte species, they are muscarine containing mushrooms. In that, those poisonings, atropine can be used. It is considered to be a drug of choice. And they can also be used, atropine and glycopyrrolate. They can also be used to antagonize the muscarinic effects of drugs and poisons. So these drugs, atropine and glycopyrrolate, can block the muscarinic actions of neostigmine in case of myasthenia gravis, decurarization, or cobra envenomation. So with that, we come to the end of this topic. We saw the therapeutic uses of atropine as well as atropine substitutes. Thank you.